Now we have Dr. Tara Collins, who's a psychiatrist, who's going to be talking about, well, she also works in supportive housing. She's going to be talking about some of the most common psychiatric and developmental disabilities and impairments as they pertain to housing and treatment modalities and accommodations to enable tenants to remain in their homes.
Good afternoon, everybody. What? I only heard two people. Hello, good afternoon, everybody. Thank you. I am very happy to be here to talk about mental disorders, neurodevelopmental disorders, and reasonable accommodations. As April just mentioned, I'm at UCSF. I work in an outpatient clinic, but I also work in a supportive housing complex where I am the psychiatrist for the building. My office is downstairs by the elevators, and I see the tenants in the building. So neurodevelopmental disorders is smaller for a reason. I'm not going to talk much about that because it's not my area of expertise. So I'm going to give an overview of mental disorders, brief epidemiology, talk about some definitions, housing-related problems and treatment options, and reasonable accommodations, and some other considerations and challenges. I'm going to go through this a little quickly. I think I have too many slides, and we're a little behind. So as everyone else has already said, please feel free to find me during the break or when the day is over, and I'm happy to go over things in more detail. So what is a mental disorder? According to the Diagnostic and Statistical Manual of Mental Disorders, which is kind of like the psychiatric Bible, it's what lists all the criteria for every mental illness. A mental disorder is a syndrome characterized by a clinically significant disturbance in a person's cognition, emotion regulation, or behavior that reflects a dysfunction in psychological, biological, or developmental processes. A mental disorder is usually associated with one of the following: either significant distress or a disability in social, occupational, or other important activities. And this is important because someone can be experiencing what we might think of as symptoms of a mental illness, say, for example, hearing voices. But if it's not causing clinically significant distress, and if it's not impairing someone's functioning, then it's not a mental disorder. So what's not a mental disorder? Expected or culturally approved responses to common stressors or losses. So for example, grief, like the loss of a loved one, not a mental disorder, completely appropriate and culturally expected. Or socially deviant behavior and conflicts that are primarily between an individual and society. Also not a mental disorder. So in the United States, in 2013, about 44 million adults had any mental illness, and 10 million had a serious mental illness, where people have significant symptoms that greatly impair their functioning. Women are more likely to have mental illness, and for any mental illness as well as serious mental illness. And often with mental illness, you can see up to 17.5% will meet criteria for a substance use disorder. And that number the percentage goes up for a serious mental illness, where it's 23%. And then you can also see that many people with mental illnesses don't get treatment, or don't receive treatment for a variety of reasons. So about 45% with any mental illness received treatment, and about 2/3 with a serious mental illness received treatment. So that's still a third of individuals who have a serious mental illness who aren't being treated for it. So I'll start with anxiety disorders, and I'm going to focus on some, again, more common mental illnesses that we'll see, and especially when it relates to housing. Anxiety disorders are the most common mental disorders present in the general population. Approximately almost 20%, about 18.5%, so almost 1 in 5 individuals will have an anxiety disorder. They're more common in developed countries and more common in women. And you can see there are some different types of anxiety disorders. The thing to really pay attention to with anxiety disorders is fear and anxiety. And fear is an emotional response to a known, definite, external threat. So if someone has a gun in my face and is robbing me, then a fear response will be evoked, as opposed to anxiety, which is more of a diffuse, unpleasant, vague sense of apprehension or unease and intense concern about danger or threat. So that would be maybe if not there's someone in my face with a gun trying to rob me, but if I'm walking down a dark alley, then I have this unease or anxiety. For anxiety disorders, the treatment is for medication management and therapy. And with medication management for anxiety disorders, typically people will first see their primary care providers or possibly even the psychiatric nurse practitioners. Psychiatrists often are not involved unless the anxiety disorder is more severe, or if a person just on their own decided to seek out a psychiatrist. But many people will first go to their primary care providers, who can definitely treat anxiety disorders, especially more mild cases. The medications for anxiety disorders, for the most part, are pretty benign. It's the same medications that we use for depression, but they take time to work. So the medications for anxiety disorders and depression can take up to 1 to 2 months before you really see an effect. And that's something that's important to know if someone's symptoms are causing them problems in their housing, that it might take a while before symptoms improve. Complementary and alternative modalities for treatment for anxiety also include acupuncture, yoga, or traditional and natural medicines, meditation, prayer, and pastoral counseling. And often all these three can work together: medications, more traditional therapy, and alternative modalities. So in looking specifically at agoraphobia, this is an anxiety disorder in which there's marked fear or anxiety about 2 or more of the following situations. So using public transportation, being in open spaces or enclosed spaces, being in a line or in a crowd, or outside of home alone. These agoraphobic situations almost always provoke extreme anxiety and fear, which is out of proportion to the situation at hand. And so people actively avoid the situations to not experience this anxiety and fear, or may require a companion to leave their home and do things. So you can imagine with housing-related problems, and people have difficulty leaving their home. So some individuals with agoraphobia are completely homebound and dependent on others for services or assistance to provide for even their basic needs. So they may have trouble being able to get out and leave to pay their rent, to pay bills, especially if they don't have access to a computer or internet or have the ability to do electronic payments. You also see a lot of food-related issues with agoraphobia because, again, people aren't able to get out and leave, so they may have more delivery of food. There can be storage issues. People like to stock up on food, especially frozen food, so that they don't have to go out. And then the disposal. I'm actually going to skip social phobia for time, but briefly, social phobia is when people have intense anxiety or fear in social settings or situations, and this can cause problems in interacting with landlords and trying to resolve issues, where often a person has extreme anxiety even trying to have a conversation, picking up the phone or writing. So it can cause a lot of problems if there are conflicts that need to be resolved. So depressive disorders are also among the most common mental disorders. A common feature of depressive disorders is having a sad, empty, or irritable mood, which is also accompanied by physical and cognitive changes. The different kinds of depressive disorders, they're different due to either the duration, the timing, or the cause. So major depressive disorder, which I think most people are familiar with, represents kind of the classic condition in depressive disorders. It can be, another thing to know about major depressive disorder is that for severe cases, they can actually be accompanied by psychotic symptoms. So people don't have to have a psychotic disorder, but can still have psychotic symptoms if the depression is severe, and those symptoms clear up as the depression is treated, and they don't have ongoing, lingering psychotic symptoms. According to the World Health Organization, major depressive disorder carries the heaviest burden of disability among mental disorders. And in the United States, in 2013, approximately 15.7 million adults suffered from major depression. So with major depression disorder, you have to have at least 5 symptoms during a 2-week period for most of the day, nearly every day. And this is the case for most mental illnesses. So it's not that you have depression for an hour or two and feel terrible and have these 5 symptoms, and then the other 22 hours of the day you feel well. It's a pervasive condition that you experience most of the time. So to have a diagnosis of depression, someone has to have either a depressed mood or a decreased pleasure in activities. One of the two of those is necessary for the diagnosis, and then you have to have several of the others. So there's a significant change in weight, whether it's weight loss or weight gain. Some people with depression lose their appetite, others, their appetite increases and they eat more. Similarly with sleeping, you can have either insomnia or excessive sleeping. There's a decreased ability to concentrate or indecisiveness. There's either a sped up kind of restless activity in the body and in the mind, or people can be slowed down. There's fatigue and loss of energy, worthlessness feelings, excessive or inappropriate guilt, and recurrent thoughts of death, and even suicidal thoughts with or without a plan, and unfortunately for other people, suicide attempts. So similarly to agoraphobia, the combination of depressive symptoms of lack of motivation, poor concentration, and low energy can also, again, lead to difficulty leaving the home, making people homebound and dependent on others for help. So different from agoraphobia, though, people with depression can also experience poor grooming and hygiene, have an unclean home, unsanitary living conditions, and also can neglect their animals or pets, which can cause problems with their housing. And these problems it's not an exhaustive list, but just to give you an idea. So with depression, there are many more treatment options available, in addition to medication management, therapy, and the complementary and alternative modalities, which were mentioned earlier. There's also electroconvulsive therapy for severe cases of depression, which most people know as shock therapy. Which is actually the most effective treatment that we have in psychiatry, and it's not as barbaric as it is portrayed in films and media. Transcranial magnetic stimulation, deep brain stimulation, vagus nerve stimulation, basically various ways that you can stimulate the brain to try to treat depression, as well as light therapy, having a light box, and even Botox. So you can clear up your wrinkles and depression. It's great. Complementary and alternative modalities. So for the next group of disorders, bipolar and related disorders. Now, in the previous version of the DSM, bipolar disorder and depression were grouped together under mood disorders, but we recognize that bipolar disorder is distinct, and in a way it's kind of in between schizophrenia and depression, so it's separated out. These bipolar and related disorders are can often be referred to as manic depressive disorders, if people are more familiar with that term. Bipolar 1 is kind of the classic manic depressive disorder, and it's characterized by dramatic shifts in mood and energy and activity levels that really impair someone's functioning. So this is different from the normal ups and downs that we can have during the day. These are really big dramatic shifts. Severe, and similarly to depression, severe mania can also be accompanied by psychotic symptoms, which can be very unnerving to people. I mean, in addition to what you're already seeing with the mania, people can have hallucinations, delusions, paranoia, and I'll talk a little bit more about psychotic symptoms later. So in the United States, about 2.6% of the adult population has bipolar disorder. So 2.6% might not seem like a large number, but trust me, that's a common condition. And if you look at this, while 2.6% of this adult population has bipolar disorder, almost 83% of these individuals have a severe mental illness. So the vast majority of people with bipolar disorder, at least according to the National Survey on Drug Use and Mental Illness, have very severe symptoms that require treatment. So with bipolar 1 disorder, again, this is kind of the classic manic depression, there has to be at least one manic episode. And a manic episode is a distinct period of an abnormally and persistently change in the mood. So people are euphoric, feel wonderful, feel great. Sometimes people say they're feeling high, they're very outgoing, Or people can be extremely irritable, which I think is something that's not so commonly known with bipolar disorder. You can have that wonderful euphoria, or you can be extremely irritable. And this is a persistent state, so it doesn't matter what's happening during the day. It doesn't matter if someone could drop dead in front of you, you'll still be overjoyed and elated. In addition to having a change in the mood, there must be increased activity and energy, which is at least a week. Now, the symptoms don't have to last for a week if someone's symptoms are so severe that they land them in the hospital after 3 days. So if you end up in the hospital after any amount of time due to your symptoms, that's mania, whether it's a week or not. There have to be some additional symptoms present for it to be a manic episode. So people have an inflated self-esteem, what we call grandiosity, unrealistic belief in their abilities. So there's this sense of, I'm the smartest person in the world, or I'm the best chess person ever, or I can fly. 1 minute, whoa. There's a decreased need for sleep. People talk more than usual. Their thoughts are going really fast. They're easily distracted, just really revved up. And a really big problem with bipolar disorder is that people can behave very impulsively and engage in reckless behavior and really just high-risk pleasurable activities. So people can become sexually promiscuous, which they're normally not, and having unsafe sex, spending lots and lots of money, putting themselves into debt. I had a patient once who spent over $100,000 in a few days. It can be really severe. Or driving really fast and recklessly and dangerously and causing accidents. So it's a big change in behavior. So with bipolar disorder, for people who are in the depressive phase of the illness, then it's similar to what I described for depression. In the manic state, you can also see a lot of complaints from neighbors. For minor annoyances, like the person's not really sleeping, they have all this energy, can be up all night making noise, or in a really severe state of mania, people can become really aggressive and even assaultive. You can see property damage. Again, as I mentioned, these shopping sprees, which then people can't pay their rent and bills, and also even in severe mania, people can begin to engage in illegal activity, which can affect their housing. So sorry, I'm going to start going a little faster. Again, you can find me afterwards. For mania, the main treatment is medication or shock therapy, electroconvulsive therapy for really severe. Therapy does not really work for mania. Yeah, we still do it. It's a very effective and safe treatment. We do it at Langley Porter, at UCSF, and also at the General. So I do want to touch on hoarding disorders. This is a really big problem. It falls in the obsessive compulsive and related disorders category. And with hoarding, there's a persistent difficulty getting rid of your possessions, regardless of their value. There's a strong perceived need to save items, and there's a significant amount of distress associated with having to discard items. And so as a result, you get an accumulation of possessions that can congest and clutter living areas and substantially compromise their intended use. So you can't use your bathroom because it's full of clutter. You can't use your kitchen because it's full of clutter. And this is not the same as normal collecting. And unfortunately, with hoarding disorders, the functional impairments and the clutter actually worsen over time if people don't get treatment, as opposed to other mental illnesses, which over time can improve. So with housing-related problems with hoarding disorder, you can have unsanitary and unhygienic conditions that pose a health risk not only to the individual but to people who visit. There can be fire hazards. The clutter can lead to insect and rodent infestations, property damage. People can sustain injuries from shifting or falling items or collapse of their big piles. It's difficult to move around, and also if you need this emergency situation, it's difficult for first responders to get in and actually help. And there's animal hoarding too, which a lot of people aren't aware of. Treatment for hoarding disorder is mostly therapy, and it takes a while. None of our treatments in psychiatry really work instantly, unfortunately. Medications are helpful as well, but you need really high doses of medication for at least 3 months. Very briefly, there are trauma and stressor-related disorders, of which PTSD most people are familiar with. And with PTSD, there's a lot of problems with constantly re-experiencing the trauma. And this can take place, this can manifest with thoughts that come into mind that we don't want to have with the trauma, or actual flashbacks, which can cause problems because people have that sense that they're in that traumatic event and re-experiencing it and living it. And if someone is outside their home or interacting with someone else, that can really be problematic. I'm going to go through this. For PTSD, it can be very difficult, especially to tolerate noise in leaving home. And as with all of our illnesses, there are medications that are helpful for PTSD, and therapy is really crucial. So for schizophrenia spectrum and other psychotic disorders, psychosis is basically, I'm going to make it much simpler than the slide. Some people are out of touch with reality. So either believing things that aren't true, having sensations that aren't there, so hearing voices when no one's present, seeing things, having visual hallucinations when nothing is there, or not being able to think clearly or behave in an organized way. Schizophrenia affects about 1% of the population. For many people, the level of functioning in schizophrenia really declines. That's not the case for everyone, and some people do very well with treatment and are able to work and lead productive lives, but for many, schizophrenia is a really disabling illness. And unfortunately, with schizophrenia, many people with this illness don't have an awareness that they have the illness, so it's very hard to get them into treatment and stabilize symptoms. Neurodevelopmental disorders. These are disorders which manifest during the developmental period, often before children enter school. They're characterized by developmental deficits that can cause impairments in personal, social, academic, or occupational function. They can range from something very specific and limited, say for instance dyslexia, to global impairments in social skills or intelligence. With our new DSM, there are a lot of new categories and names for these, for the neurodevelopmental disorders, so for instance, intellectual disabilities was formerly called mental retardation, and the autism spectrum disorder now encompasses Asperger's, which is not in the new DSM-5. I'm going to go through this quickly. With intellectual disabilities, I think the important thing to know is these have to be confirmed by both clinical assessment and standardized intelligence testing. These are developmental disabilities are in about 1% of the population, with men more likely to be diagnosed than women. And the same for autism spectrum disorder. So with reasonable accommodations, I'm going to skip most of this because a lot of what I was going to say has actually been covered. There's no kind of, list or something that you can refer to like, okay, you have depression, so you're going to need these accommodations. And you have schizophrenia, so you're going to need this list of accommodations. Everybody with a mental illness is different. Everyone has a different combination of symptoms, a different manifestation of their illness. So it's really important to work with individual people and come up with a plan and find out what their limitations and disabilities are and what's going to be a reasonable request to make to the landlord. As was already mentioned, one of the most common requests is for an emotional support animal or a service animal, which I get asked a lot to write letters for that. And the difference between service animals and emotional support animals was already talked about, so I'll skip that. And also, as it was already discussed, that for housing, you can have a reasonable accommodation for emotional support animals, but just for housing. So I will skip that. Just kind of random examples of reasonable accommodation, because again, it depends on each person and who you're working with. So there can be requests to be transferred to a quieter unit without any penalties or problems for breaking the lease. Someone, as I was saying, with agoraphobia, who has difficulty leaving their home, might request to have an additional freezer in their unit to store larger amounts of food. Being able to mail in a check for someone with social anxiety, perhaps, instead of having to go to the office and drop it off. Or for someone with social phobia who has difficulty talking on the phone, being able to communicate only in writing, or the opposite if that's easier. As was already mentioned earlier, holding off on eviction until people actually have a chance to engage in treatment and try to improve their symptoms. Having assistance completing housing applications, and maybe getting a reference from a social worker if someone hasn't worked. And then also, again, was mentioned earlier, many people with severe mental illnesses have others who are involved in their care and help them on a day-to-day basis. They can have an IHSS worker, a payee, a case manager, other people who may need for a reasonable accommodation to have them help assist with their various housing issues. So this is the last slide. For challenges, at least for what I see as a lot of challenges and troubles with my patients, is that our treatments take time. We do not have any fast, quick solutions to helping someone get better. It really does take time. I would say at the minimum we need at least a month or more before we can really start seeing improvement in symptoms, and so this can be difficult in trying to address these housing matters where someone is still decompensated for a significant period of time. And then even patients who are totally complying with their medication, taking them just as prescribed, there's still some people that are going to have significant symptoms, whether they're complying with their medication or not. Or there's still going to be times when people experience stress and it's going to cause a flare in their symptoms. One of the problems that I have is not being able to get information from others who are involved with my patients so that I know when they're starting to not do well, if they're not coming to see me. So it's nice to have either a psychiatric advance directive, which someone can complete when they're stable, to say, you know, if I decompensate, if I lose the ability to make these decisions for myself, this is how I want my treatment to go. This is what I would like to see happen. And again, many people with severe mental illness don't have insight into their condition. So there are things such as long-acting medications, which we can give an injection. So instead of relying on someone to take a pill every day, they can get an injection every 2 weeks to the longest injection we have now is every 3 months. There's also intensive case management, supportive housing, which is what I also do, and Laura's Law for outpatient commitment. So I went a little bit over, but tried to give you all an overview, and please feel free to find me during the break or after.
Them, they can ask, otherwise keep moving.
So does anybody have a very specific question for Dr. Collins before we move on? Oh, there's someone over here. CJ to your right. Sorry. There you go.
Our office takes housing complaints quite frequently from both city-funded housing and from private housing. And one of the things that comes up around reasonable accommodation is not just the interactive process and getting the letter from your provider, but the nexus between the accommodation and the disability sometimes gets lost. Can you talk a little bit about making sure that that occurs when people are asking for that accommodation?
So, is this on? Okay. Yeah, you know, I can answer for me because it's much easier for me than a lot of other psychiatrists in the community, where in my job I have the ability, it's actually part of my job, to go out to people's homes. So I do a lot of home visits. I do a lot of face-to-face with clients in their living space, and if need be, with their landlords. So for me, to answer your question, is I just get directly involved. In the supportive housing where I live, I'm in the building. My office is right across the hall from the property management. For my other patients, then I'll go out. I'll either, if they give me permission, and it could be a limited release. I don't have to, give a lot of information, but if they give me permission to, then I will personally follow up and see. It's actually good for me to go to the homes because then I can get a better sense of what a reasonable accommodation would be, and then to help them along with their case manager talk to the landlord, and then have the ability to follow up to see what happened. But I'm fortunate in that I work in a clinic with intensive case management, and we can do that. It's a lot more difficult for other psychiatrists, especially if they're just in a small private practice.
And what we do when we're doing our investigation is we interview the doctor to make sure that there's a nexus.
Let's see if we can get a microphone. They'll get a microphone to you.
Hi, my name is Jane Warren. and I'm with the on the board of directors of the Autism Society in San Francisco, and I have something I need to read, and it's about the case of recently. There's been a lot of press about the 9-year-old boy in Sunnyvale whose family is being sued for noise and garage things that are missing, and they're trying to get him declared a public nuisance. So the press, including Good Morning America, was not always helpful in this situation or sympathetic to the special needs of the family. So far as the claim of their property values were being negatively impacted, the one question I have is, what can be done to improve the attitude in the neighborhood and to prevent this from happening again? And my second question is, what can be done to get adequate supports for people with challenging behaviors and may have dual diagnosis? This is currently very underfunded, as you know, and so far nothing has been done in the special session that the governor requested to address the underfunded DD system. So those are my questions.
Okay.
So I found that psychoeducation or education is one of the first steps. A lot of times with all mental illnesses is that there's not enough of an understanding of what the mental disorder is, how it manifests, what the treatments may be. And I find that, especially with my patients, when I'm trying to work with them, even just with their families, before we even move out into the neighborhood and the community, of being able to sit down and just explain. I find that alone really, for a lot of times, will do so much when people can just get an understanding of what's happening. And also, but not just an understanding, but at least a bit of a timeline, so people have a sense of, okay, so what's going to happen, what are the changes, what can we expect to see, so that it's not just, okay, I understand that this is an issue and it's just going to be like this forever, and what. So I also try to talk to people about, here's what's happening, these are the steps we're taking, this is kind of the timeline of what we can look forward to. We can try to reassess and come back and talk with you again to get a sense of how things are going for everyone involved and modify the plan as needed. But again, kind of what I was saying earlier, that's difficult for a lot of treatment providers to actually do, to find the time and the resources to do that and to get everyone available to make that a possibility. But that's what I would do.
Okay.
Homeowners who moved a year ago,
Mm-hmm.
and they're trying to have this person's son, Hugo's son, declared a public nuisance.
So people have actually already sat down with them and went through what's happening, and well, some people are just not going to change, which is an unfortunate part of life. Some people just aren't going to change, and as you mentioned, mental health treatment in this country is so underfunded, and there are not a lot of resources available. I'm not a child and adolescent psychiatrist, so I'm not that familiar with the options for children. But I know people, I can give you information. I know other child and adolescent psychiatrists and who are down in that area who might have better information for you.
Thank you. So now we'll move on to Joe Femino, who's a director of housing for the San Francisco ARC, and will speak from the perspective of independent living housing provider.
Yeah.
Thank you.
Hi, I'm Joe Femino. I work for the ARC San Francisco. I'm going to talk a little bit from the service provider's perspective. We're going to talk a little bit about what the ARC does, why the ARC became a housing provider, the philosophy behind supported living services, how it affects all aspects of life, some issues, challenges, and some solutions. So about the ARC was started 64 years ago by parents who were unsatisfied with the lack of services for their adult children with disabilities. The ARC is the largest service provider for, serving persons with developmental disabilities in the Bay Area. The ARC takes a whole person approach to services and tries not to limit support by, by different services. And in housing and residential, we serve about 80 persons currently. We provide 4 different types of housing services, and currently we're the key partner developing 2 new apartment buildings, which will eventually be about 35 units of housing for persons with disabilities. Our funding sources are Golden Gate Regional Center, Department of Rehabilitation, and then our development department in fundraising. So the reason we became a housing provider, we're basically, I think the conversation started with parents who were, worried about what was going to happen to their adult children, once they passed away. They were concerned, where they would go. Our participants were telling us that they wanted more privacy and fuller social lives and self-determination. So also, housing is the key to independence. One of the issues that come up is, from landlords who, it's not as bad as it used to be, but, are hesitant to rent to persons with developmental disabilities. So these are kind of the top 3 questions that I get sometimes. What if their condition gets worse? They're concerned about liability issues. What if they hurt themselves on our property? Will they have the capacity to take care of the place? Why is independent living so important? The ARC, and I think a lot of people in this room believe that everyone should have the right to live the least restrictive, most integrated setting possible. Everybody should have the right to pursue relationships and have privacy. It takes independence to make the good and bad choices that we learn and grow from. And also, we found that people do better at their jobs and are more successful in life in general when they have a full, well-rounded life. We found that persons that are satisfied with their home life, retain their employment longer and are more successful. Our participants historically haven't been terminated from their jobs for technical ability. It's usually been social skills related issues. So again, housing affects all aspects of life. Living independently can open up social opportunities where they previously were none. Limited privacy and curfews impact full opportunities for social relationships. Again, our participants were telling us that they where they lived, they didn't have privacy. They're sharing a bedroom. They had curfews. They had to be home by 8 o'clock, and it was really tough to have friends and relationships. Participants who had a rich social life and privacy in a home they were proud of were more successful, retained employment longer. I already said that. Okay, so there's 4 types of residential and housing services that the ARC offers. There's independent living services, supported living services, supported living apartments, housing search, and advocacy. I'll just break those down a little bit. ILS, independent living services, are for participants who have a moderate amount of independence, and it's usually between 15 and 50 hours of in-home instruction per month. And we help people with just kind of the basics of cooking, shopping, bill paying, household maintenance, medication monitoring, accessing neighborhood resources. SLS is for persons who have more intensive needs and are possibly medically fragile. And that's usually from 50 hours to 24/7 assistance. And we do that in coordination with other agencies, IHSS, in-home support services, other providers sometimes, assist with the care of the tenants, and sometimes family support also. In addition to the supports I listed for ILS, we also have overnight supervision, assistance with medical appointments and medication monitoring, and substitution coverage for other services that the participants are in. Supported living apartments it's a semi-supervised roommate situation for participants that have a higher level of independence. There's a manager that lives, in the same apartment complex but not in the same unit as the tenants. The ARC is a master leaseholder for this, and the instruction provided for daily living skills is very similar to the ILS, the first service that I mentioned. Housing search and advocacy is our fourth service. We assist persons in obtaining and retaining housing, which is not an easy gig right now. We'll also advocate for participants and tenants when needed if there's any kind of dispute or misunderstanding with landlords and neighbors. We'll help a tenant understand their lease and what their obligations are to go along with it, and we'll mediate when needed for landlord-neighbor disputes. And let me see some issues and challenges on being a landlord and a service provider. Assisting tenants to, in some situations, tenants will, screen their potential new roommate, and so we kind of use it as a teachable moment to help our tenants, to make sure that they're not, being discriminatory, to make sure that they're being legal and above board with their possible new roommate. Oops. Let me see. Another challenge is service guidelines and lease violations are not always compatible. I'm going to talk a little bit more about that in a second. Master leaseholding, like I said, for the SLA service, it's a nice opportunity for persons who don't have a credit background or rental history, who probably wouldn't get into an apartment, to be able to get into the apartment. The downside to it, though, is that if somebody defaults on their rent or damages the property, they're not liable for it. The ARC would be, or the master leaseholder. Let me see. A service provider has no authority to evict. Not that we're generally looking to, but the tenants are subject to the same process as anybody else. The reason I put this in here is I'll get calls every now and then that will, just say, from, somebody else in the building or a neighbor saying, we don't feel like this is a good fit. Can't you just, place them somewhere else? And, they have the same rights as everybody else, as they should, and, are subject to the same, eviction process. Often also behavioral issues, including some what we would consider maladaptive behavior, self-injurious behavior, are not lease violations either. And I think there's a lot of misconceptions around that as well. Let me see. So some sort of solutions. As I said, use teachable moments when possible. Educate tenants on discrimination and what is not okay to ask, what is okay to ask. Potential new tenants. Keep services and lease agreements separate. I think is a really good idea, because it's two very different hats to wear, and sometimes the legalities also don't, as I said, don't necessarily correspond to service agreements. Also, like our main funding source, Golden Gate Regional Center, won't any longer even fund that model. That of somebody being having a vested interest in also providing services. Let me see. And I think, also maintain, collaborative partnerships, with, property management companies, which is kind of what we're doing in our newer models. They can handle the leases and the lease agreements and all that, and we can kind of stick to services. That's just about it. I just wanted to also, I mentioned that we're partnering up for 2 new buildings that are slated to open up in about a year and a half. And that'll be 35 units of housing for persons with disabilities, so we're pretty excited about that. So there's going to be one at Page and Masonic, and there's also one at 206th Street that used to be that building that had all the furniture hanging off of it. Yeah, it's gone. The furniture was actually, people, it sort of held up the project a little bit because, people really liked the furniture, and I liked it too, but it actually was like rotted and full of, rat droppings and really gross if you got up close to it. So, anyways, so that's all I have. So, thanks.
Joe, one of the underlying discussions throughout this public awareness event, especially among landlord and tenant attorneys and evictions, is the ground of nuisance for eviction. And you and I spoke briefly at the beginning of this about whether it's in supportive housing, whether it's a residential program for people with severe mental illness, whether it's the psychosis or schizoaffective disorder, combinations of mood disorders and psychosis or personality disorder, there always seems to be, and even with no disorder, altercations. I mean, human beings and like other species fight from time to time. And on the one hand, you have an alleged interference for peaceful and quiet enjoyment of the abode, and then you have the accused person, let's say in this instance, with, let's say, a combination of developmental disability and someone on the autism spectrum. And I just wondered if you can comment a little on that as to conflict resolution. There is no residence or apartment where you're going to put a group of people where there's not going to be disagreements or people getting very upset and or actual fighting. Now, the ILS trainers, there may be 24/7 versus the social worker in another kind of mental health placement where there's an MFT in charge. But I just wondered if you can comment a little more on different methods of resolving disputes which rise to the level of maybe someone has to be evicted or kicked out or placed somewhere else or wait online for an opening if there is somewhere else.
Sure. Yeah, I mean, I come at it as from a service perspective first. We do a lot of mediation, between tenants and our different buildings. Sometimes we just, simple as, having house meetings to try to, because we try to have them, work it out as often as possible, as much on their own as they can. So, we mediate that way. We do house meetings. We, also the group can kind of, come up with, as long as it's legal, guidelines for the house, for the apartment. So, and then, my next step would be, we'd look at what services is this person not getting, to try to help them. If there is, one person that's kind of the issue, what services aren't they getting that, that we could kind of enhance that would, help them, get along in this situation. And then, sometimes it does kind of cross that line where it can, I guess, qualify for eviction. But hopefully it doesn't get to that point. Did that answer your question?
I guess what you're saying is, there are a lot of approaches, including mediation, and maybe someone needs more services in one area, or maybe different parties need different kinds of services to have a successful mediation, and eviction
It's kind of the same issues as the general population.
sort of the last resort. I'm paraphrasing the best I can, but in essence, that is what you're saying?
Yeah, absolutely. Yeah.
Right.
Yeah.
Okay.
Yeah.
Thanks.
And again, I think it's like misconceptions that we can just kind of, pull somebody out of an apartment if there's a problem, and, which, we can't, not that we want to anyways, but, it's the same procedure as general population. So.
Right. Thank you very much.
Yeah.